Welcome to our educational series on emergency medicine. Today, we'll be discussing bleeding, one of the most critical conditions you'll encounter as a medical professional. In this video, we'll walk through the classification of hemorrhage, essential diagnostic steps, and evidence-based treatments, including medication doses and practical interventions. Bleeding, also known as hemorrhage, occurs when blood escapes the circulatory system. It can be minor or life-threatening. In emergency settings, your speed and accuracy in managing hemorrhage can mean the difference between life and death. Key priorities include locating the source, stabilizing the patient, administering appropriate fluids and blood products, and securing definitive treatment. We can classify hemorrhage by source. Arterial bleeding is bright red and pulsatile, venous bleeding is darker and more steady, and capillary bleeding often presents as a slower oozing. Location bleeding can be external or internal. Internal bleeds are especially dangerous because they can remain hidden until the patient becomes hemodynamically unstable. Volume loss. In adults, we categorize volume loss from Class 1 to Class 4. Class 1 is up to 15% blood loss with minimal clinical signs, while Class 4 represents more than 40% loss and is immediately life-threatening. When a patient arrives with suspected hemorrhage, follow the ABCDE approach. A. Ensure the airway is patent. B. Evaluate breathing and oxygenation. C. Assess circulation by checking vital signs, controlling obvious hemorrhage, and looking for signs of shock. D. Quickly assess neurological status, disability. E. Expose the patient to identify any hidden bleeding sources while preventing hypothermia. Simultaneously begin resuscitation and bleeding control. Apply direct pressure to external wounds, use tourniquets on uncontrollable extremity bleeding, and establish 2 large-bore IV lines or IO access. Start rapid fluid infusion and prepare for blood products. Monitor vital signs closely with continuous ECG, pulse oximetry, and end-tidal CO2 if the patient is intubated. Obtain lab tests, CBC, coagulation panels, type and cross-match lactate, and use imaging like FAST or CT scans to identify internal bleeding. Major hemorrhage requires hemostatic resuscitation, utilizing blood products, packed red blood cells, fresh frozen plasma, platelets, and cryoprecipitate in a balanced ratio, often 1:1:1. Tranexamic acid, or TXA, is a critical medication for suspected major hemorrhage and trauma. The typical dose is 1 gram intravenously over 10 minutes, followed by 1 gram intravenously over 8 hours, ideally started within 3 hours of injury. Fibrinogen concentrate or cryoprecipitate is administered if fibrinogen levels are low, below about 1.5 to 2 grams per liter. Additional medications include vasopressors like norepinephrine for persistent hypotension despite volume resuscitation, and prothrombin complex concentrate, or PCC, for rapid correction of coagulopathy, particularly in patients on warfarin. For partial warfarin reversal, vitamin K, 5 to 10 milligrams intravenously, can also be given. Treatment also depends on the anatomical site. External extremity bleeding requires direct pressure, wound packing, and tourniquets as needed. For chest bleeding, such as hemothorax, place a chest tube or thoracostomy, and monitor the drained volume. Abdominal bleeding necessitates the use of FAST or CT to diagnose. Surgical interventions like an exploratory laparotomy or interventional radiology procedures such as angioembolization may be required. Pelvic bleeding needs stabilization with a binder and consideration of interventional radiology for embolization if appropriate. Vascular injury requires surgical exploration and repair or endovascular techniques. In severe trauma, damage control surgery focuses on rapidly stopping bleeding and contamination, with definitive repairs possibly delayed until the patient is stabilized. Interventional radiology can be a valuable adjunct for stable patients. Once the patient is resuscitated, correct the triad of death, hypothermia, acidosis, and coagulopathy through active warming, adequate ventilation, and targeted blood product support. Admit the patient to the ICU for continuous monitoring and repeated lab work. Initiate thromboprophylaxis with low molecular weight heparin once bleeding is controlled and there are no contraindications. Plan for rehabilitation, wound care, and further surgical interventions if necessary. To recap the most important medication doses, Tranexamic Acid or TXA 1 gram intravenously over 10 minutes, then 1 gram intravenously over 8 hours. Blood product ratios aim for 1 to 1 to 1 of red blood cells to fresh frozen plasma to platelets. Vitamin K 5 to 10 milligrams intravenously for partial or non-urgent warfare and reversal. PCC dosage is based on INR and weight, typically 25 to 50 IU per kilogram. The key to saving lives in hemorrhagic emergencies lies in rapid recognition, effective hemostatic resuscitation, and controlling the source of bleeding. By understanding the pathophysiology, applying the correct protocols, and collaborating with an interdisciplinary team, you can optimize patient outcomes and minimize the complications associated with massive hemorrhage. Thank you for watching this comprehensive guide on managing hemorrhage. We hope this information will enhance your clinical practice. Stay safe and stay prepared. Lives depend on it.